Hi, I'm Elizabeth Angier,
I'm Kelsey Mickelson.
and this is our presentation on nutritional rehabilitation, practical guidelines for refeeding patients with anorexia nervosa. In recent years, eating disorders have received greater public attention. Studies have been conducted to determine the best treatment options, to better understand the client's self-perception, and to research the benefits and deficits of life in an inpatient versus outpatient unit. Additionally, the DSM has become a working document to stay updated with the various characteristics of ED. Outside of clinical setting, however, the media and the news sources have made this information more available to the public, to the point where eating disorders have often become stigmatized, glamorized, and normalized. However, there is a side of EDs, specifically a side of anorexia nervosa, that is less discussed, and this is the topic that Meller and Anderson expose in Chapter 4 of their book, The Process of Refeeding and Nutritional Rehabilitation. That's what we're exploring today. And this looks at the darker side of anorexia nervosa and the first stages of the journey toward mental health that both patient and clinician must face. In addition to the physical components of the eating disorder, patients whose ED has become a core component and a coping mechanism in their lives often struggle with resistance to get healthier. The counselor, on the other hand, must consider both best practice and the patient's interests. If there is one thing that this chapter makes very clear, it is that it is often necessary to implement drastic measures such as the refeeding process. Sometimes it is necessary to make difficult decisions and to take a conflicted stance that is in direct contradiction to the patient's desires in order to literally save their lives. This has to be done before you can even begin to reorder the patient's self-perception. As Meller and Anderson note, without a concerted refeeding effort, no meaningful psychotherapy can take place because these patients have starvation-induced cognitive deficits. This chapter is so necessary for the counselor to consider because it honestly assesses what the refeeding looks like if it is done well, poorly, or not at all.
The first way friends and family can help someone struggling with an eating disorder is to understand that eating disorders are a mental health disorder, categorized by more than not eating. Sufferers carry a weight of serious ailments. Philip and Anderson share two case studies verifying this point. One is of J.W., who has a 15-year history of anorexia. She was committed to inpatient after attempting suicide with self-inflicted stab wounds. Second is of S.C., who was readmitted to inpatient due to losing 29 pounds in 18 months, leading to her being infected with fungal pneumonia. So be humble and educate yourself. If someone you love has an eating disorder, remember you are not the expert. While you may want to help, know that encouraging eating is not helpful. Refeeding can have serious consequences, such as congestive heart failure, when not led by a professional. The best thing you can do is admit you don't have the answers, but you can still be supportive. As learned by the case studies, anorexia can lead to attempted suicide and serious physical ailments. The best support you can give is encouraging them to seek professional help because they are worth it. If treatment is sought, know that the treatment process is rigorous, so be kind and gentle while they recover.
Chapter 4 specifically addresses refeeding clients with anorexia nervosa, and utilizing the resources presented in this chapter have three primary advantages for the client. First, the obvious advantage is that the refeeding process saves lives. It might appear disturbing, but it does have that promise. Refeeding provides the opportunity for patients to reach a stabilized weight where their bodies are no longer in starvation mode, with the intent to begin addressing other non-physiological components of their ED. Therefore, clinicians must approach the refeeding process with a sense of urgency, knowing that the rapid rate of decline for this disorder. Secondly, according to Meller and Anderson, a client's awareness of the consequences that the ED has on their body could spur an individual to seek treatment. Throughout the refeeding process, the target weight gain should be discussed with the patient in order to reach an agreement and restore some patient autonomy. This book specifically recommends discussing metabolism changes with the intent to help patients understand how their body is changing, how their weight gain will prevent future difficulties, and reduce overall stress surrounding the process of recovery. Finally, this resource and the reading the success stories of those who've gone through the refeeding process already can offer hope to patients by revealing that the effort they put into treatment is buying them a healthier future.
This chapter provided great information for clinicians to treat an eating disorder. As a clinician, your first step is to determine if there's an eating disorder, then determine the severity. There are two ways to do this: measuring body mass index and ideal body weight. BMI is a standard measurement based on height and weight but it is ineffective since it does not provide any measurement of body composition or nutritional status. A better measurement is ideal body weight. This is calculated as 100 pounds for 5 feet of height, then 5 pounds for each additional inch. So someone who is 5'5" would have an ideal body weight of 125 pounds. After measuring ideal body weight, the patient is classified as mild, moderate, severe, or critical, based on if they are 10, 20, or 30% or more below ideal body weight. An important factor to consider before starting the refeeding process is that there has to be an agreement among the caregiver, dietitian, and patient as to what the target weight is going to be. Once treatment has begun, the clinician needs to be aware of refeeding syndrome. Refeeding syndrome typically occurs in significantly malnourished patients and can cause reduced cardiac size due to the weight loss. This makes it difficult for the heart to handle the increased blood circulation when refeeding, which can lead to heart failure. This is why it is critical to refeed an inpatient. Congestive heart failure can occur due to changes in serum levels of phosphorus, potassium, and magnesium, primarily from glucose in food. Therefore, clinicians must check serum phosphorus and electrolyte levels daily for the first 1 to 2 weeks. When refeeding, the best approach is to start low and advance slow. Slowly increase daily calories by 300 to 400 every 3 to 4 days, with an ultimate goal of consuming 3,000 to 3,600 per day. The typical goal for inpatient is to gain 3 to 4 pounds per week and 1 to 2 for outpatient. When refeeding begins, the meal plan should be individualized and can be augmented with a liquid diet. Typically, protein does not exceed 2 grams per kilograms of body weight, and macronutrients should be approximately 50% carbs and 25% protein and fat. Generally start at 1,400 to 1,800 calories per day and advance by the 300 to 400 calories per day. Again, vitally important to monitor phosphorus and electrolyte levels for heart health. Lastly, it is recommended to begin with low lactose and a low fiber diet. While treating anorexia is strenuous, difficult, and potentially dangerous, it is possible. As represented by the case studies, both individuals succeeded with inpatient treatment and kept the weight gain post-discharge. JW was maintaining her weight of 118 pounds for 3 years post-treatment, and SC has maintained hers for 2 years. For both believers and unbelievers, Jesus has offered redemption for every situation, and as clinicians, we can extend Jesus' redemption to others. Psalms tells us to hope in the Lord, that with him is steadfast love and plentiful redemption. God has sent redemption to his people and has commanded his covenant forever. No matter how bleak, patients can have the hope of loving themselves and their bodies. Poet Nairia Wahid quotes, "And I said to my body softly, I want to be your friend. It took a long breath and replied, I have been waiting my whole life for this."
As far as critiques of this chapter went, the book cited utilizing the BMI and the IBW as tools to measure ideal and healthy weight for individuals. However, neither of these measurements take into account variation of body types, both ignore the set weight that many bodies naturally settle into, and neither consider scientific research that suggests that overweight individuals can actually present just as malnourished as individuals with a lower physical weight. Ovio Bermudez, an executive ambassador for the Eating Recovery Center, posits that, due to stigmatization, many individuals silently struggle with ED, their side effects, and never ever receive clinical help that they need because they don't have the body weight that is generally associated with anorexia nervosa. Additionally, the chapter spoke with great confidence in the success of the refeeding process, but failed to discuss the complexity or respect the inadequately researched aspects of this disorder. Ironically, the chapter that recommended and discussed refeeding processes also cited articles such as Graham et al.'s 2015 study titled Refeeding and Weight Restoration Outcomes in Anorexia Nervosa, Challenging Current Guidelines. This article confessed that the frequency of relapse after discharge due to only partial weight restoration and openly acknowledged that, quote, Treatment guidelines are largely based on best practices or clinical competence rather than on more robust evidence.
For me, I miss seeing the emotional side and the psychological side of refeeding. What does the patient feel like during refeeding? What are they thinking? How could I, as a counselor, best support them emotionally and mentally? On the other hand, the scientific emphasis on how rigorous and dangerous refeeding can be reveals how serious eating disorders are and that they deserve attention.
In conclusion, Kelsey and I consider how this knowledge regarding the refeeding process would affect us as counselors, and how would it impact the way we engage with future clients. One of the things that we both recognize is that eating disorders demand respect for the complexity of treatment and that they require a team of experts. As future clinicians, we must engage a multifaceted approach and include other professionals such as psychiatrists, psychotherapists, nutritionists, dietitians, doctors, and nurses.
This chapter has also taught us the continued importance of being humble. This is a serious disorder, and you can do more harm than good if you're not trained and skilled. So we say to ourselves and to others, be humble and realize when you may need to recommend a patient to someone who is more skilled than you are. Overall, learning how an eating disorder can take someone's life through malnourishment, suicide, or if refeeding isn't done correctly, encourages us to advocate for the treatment of eating disorders, and to be mindful if future clients are struggling with an eating disorder, and to take an immediate response. Our final thought is that there is no look to an eating disorder. Any person could be suffering, and as counselors, it is our responsibility to break the stigma. Thank you all for viewing our presentation on nutritional rehabilitation, practical guidelines for refeeding patients with anorexia.